So I think that was a fantastic overview of so-called classical EGFR mutations. And so what I wanted to do is spend 15 minutes with you to go through what are known as the uncommon EGFR mutations. So if we go to the next slide, I'll just show some of my disclosures. And I'm going to break this down into both, the atypical EGFR mutations, and then separately discuss exon 20 mutations. And we're going to talk about what's known as small molecules, as well as antibody-based treatment. So thinking about EGFR mutations, Jack just gave a terrific overview of the so-called classical mutations. But if we take a step back, like how do we even think about all of these different mutations? And essentially, this is a schematic of the EGFR gene. And the way I think about this is just like a street. So think about different genes as different streets. And if you look on an individual street, there are different addresses along the street. And so the same is true for a gene, so that there are different addresses. So the classical mutations are at addresses in exon 19, and then a specific address at 858, this L to an R. And so there's a specific nomenclature that oncologists will use. And so if you're ever looking at your molecular testing report, you'll see, combinations of letters and numbers. And what they're telling us is this specific address. So I'm going to talk to you about the other 15%. So classical mutations make up about 85%. I'm going to talk to you about the other 15%. So if we go to the next slide. And the analogy I like to use in clinic is that of a baseball mitt and a ball. Because essentially, if we think of this image here as the normal EGFR receptor, and then the ball fits right in the glove, each type of mutation can essentially create a different pocket. So they can, one might look like a catcher's mitt, more of a catcher's mitt, some like a first baseman's glove, for those of you who are familiar with baseball. So essentially the pocket is a little different for all of these. And what can sometimes happen is sometimes the pocket is so similar to the normal pocket that it gets really hard to develop a drug that can distinguish, the mutation versus normal, and that can lead to side effects. To extend this analogy even further, sometimes, Jack was describing new mutations developing as a mechanism of resistance. That I visualize in my head is essentially, suddenly the whole glove pocket changes, and suddenly the ball just is no longer able to fit inside. So essentially the same thing is happening within the cell. And so if you look at the next slide, this is now a more complicated way of looking at it, but it's depicting that same thing, that the different mutations along the EGFR gene create different pockets, and these are just illustrations of what those pockets look like on a molecular level. So if we go to the next slide, this is relevant because the pocket is essentially where these drugs are binding, and so you've now heard about different generations of drugs. The first generation drugs, these are reversible, so they can bind but then come off. And one of the challenges is that with the first generation drugs, they cause more skin toxicity and diarrhea than we see now with the later drugs. And so essentially the closer drugs are to blocking that wild type, which is in medicine the normal, the more rash, diarrhea that you see. So first generation's on the left. In the middle, these are the second generation drugs. I would say that what distinguishes these, they're irreversible, so they bind and then stick, but they have a lower therapeutic window. So essentially, yes, they can target the mutations of EGFR, but they're also very close. They can also target the normal EGFR, and so these are generally associated with more toxicities. And then finally, the third generation drugs that you hear a lot about from Jack's talk, these I would say have the best therapeutic window. So if we go to the next slide. So why am I talking about the different generations of these drugs? So, when we start thinking about those atypical mutations, it's really the second generation drug, afatinib, that has an FDA approval specifically in that setting. And it was based upon this study. This was actually an analysis that was pooled together data from 3 different studies, LUXLON 2, 3, and 6. If you go to the next slide, you'll see that in this analysis, they broke the different types of EGFR mutations down. I'm going to focus mostly on the data on this group 1 on the left. These are these atypical mutations, and you can see if you just look at this, we call this type of figure a consort diagram. If you look at the types of mutations, you can see that nomenclature that I'm describing, where it's describing specific locations along the EGFR gene, and then when there's been alterations like a switch, a misspelling, where it should normally be a G and it's switched to an X. In this setting, apologies, sorry, I'm solo parenting today, so multitasking here. Essentially, if you go to the next slide, this is one of those waterfall plots again. And this is, so we want to be focusing on the green bars. That's that group 1, which are those atypical mutations. And we can see with afatinib, the second generation drug, that we can see that a majority of those bars are going down and indicative of tumor shrinkage. And so it's really this data that formed the basis for the FDA approval of afatinib. Now, for those of us who use afatinib, we know that this is a drug that is associated with a lot of diarrhea, rash. It's not the easiest drug. And so, even though there's a specific FDA approval for these atypical mutations, I tend to favor using osimertinib, even though that's not strictly the label. Now, if you go to the next slide, we see some of the data that, in my view, supports using it. So this is a study. This was a study that was done in South Korea. This is a phase 2 study. If you go to the next slide, this is using osimertinib or Tagrisso. Here, the authors have displayed the data a little differently. So it's still one of those waterfall plots, but here they're using different color coding to illustrate the different types of mutations. So it's really critical for oncologists not just to refer to this tumor as having an EGFR mutation. The specific mutation matters, and so it is important to know. And even now, I'm grouping atypical mutations together, but we do know that there are subsets within it that are more or less sensitive. And some patients actually have a combination of 2 mutations together, as illustrated by the purple bars here. And I liked Jack's figure of the stool with different legs. And really, that's what drives my use of osimertinib in the setting, in that it's the balance between activity as well as safety profile. So if we go to the next slide. So now I want to focus on exon 20. So this is illustrated in blue there. And exon 20, I would say, has been a challenging target. Fortunately, I think there's a lot of reason for optimism based upon the data that we've been seeing over the last 2 years. But one of the reasons it's been challenging is that if we go back to our baseball glove analogy, is essentially the pocket that the EGFR exon 20 mutations form is so similar to the normal EGFR pocket that if you develop a potent drug to target it, it's also targeting normal and it's leading to intolerable side effects. So that's been the challenge of exon 20, is that it's a chemistry problem that is developing drugs that can uniquely bind in the pocket while sparing the wild type. So if we go to the next slide, I want to distinguish the two types of therapies that we're going to be talking about. So on the right, I've listed TKIs, tyrosine kinase inhibitors. These are oral agents. So we've talked about first, second, third generations. These have short half-lives, so they don't stay in the body very long, typically hours to days. And then they actually, the way they block EGFR is from the inside. So if you look at the figure, you see EGFR TKIs are within the cell. So they're binding the kinase domain. That's the activation sending signals domain. By contrast, antibodies, so bullet points on the left, these are intravenous, they have a long half-life, and they bind on the cell surface, and illustrated by the yellow antibody schematic. So they bind different regions. Go to the next slide. And so first going into the targeted therapies, the small molecules. This is taken from a now old review from Dan Costa from Beth Israel, but I include it here because it's really the initial data, or summarizes a lot of that initial data, showing that the first generation EGFR inhibitors, which were the standard of care up until very recently, showed relatively limited activity against the exon 20 mutations. You can see in a number of these studies really no responses, albeit these are essentially case reports. And Dr. Costa and his team, they kind of added things up. They saw about 15% of patients with exon 20 mutations actually responding. It is important, the specific mutations are actually listed on that first column. It is important for your oncologist and as well as our patients to understand what specific mutation that is present, because some of them actually are sensitizing. So that this is not just one group, that the specific mutations matter. If we go to the next slide. And so there have been recent strategies of trying to take osimertinib, for example, and see if osimertinib is able to overcome exon 20 mutations. This is data presented by my colleague, Dr. Piotrowska at ASCO last year. And importantly, they didn't use the standard dose osimertinib here. They actually used a double dose, 160 milligrams. And I would say it showed modest activity, so about 25% response rate in this study. So not nearly as high as what we're seeing with the classical mutations. Again, speaking to the biochemistry problem. If we go to the next slide, as a result of I would say inadequacies of the standard EGFR inhibitors, there's been a concerted effort to develop newer, better targeted therapies for EGFR exon 20. I think there was a lot of enthusiasm with this agent early on, Poseotinib, based upon the initial report on the right. This was a single institution study done at MD Anderson, and you can see it showed a 43% response rate. Unfortunately, in a larger study, Zenith 20, the waterfall plot being on the left, the response rate came down, I would say, pretty significantly. So to about 15% of patients responding. I think one of the challenges of this drug that's not well depicted on this figure is the toxicity profile of this drug, and it goes back to that. What I was describing of how similar the pocket is to normal, in that a majority of patients receiving this drug had to either interrupt or reduce the dose. So it's a potent drug, but also potently inducing toxicity. And so I think the path forward for this is going to be more challenging, just given that toxicity profile. Go to the next slide. Another agent, mobocertinib, aka TAK-788. So many of these drugs, when they're first being developed, they just have a few letters and numbers, and then they graduate to having a name. So mobocertinib has graduated so that it has a name now, and I think people are hopeful that this agent will soon be FDA approved. This is data that we saw updated at ASCO, that same annual meeting that we just Jack mentioned. So, this agent, I would say, has shown some moderate activity with a response rate of 28%. It's not a home run, so I think we're still kind of learning. We still need better drugs in this place, but this is at the same time a drug that is clearly working better than the earlier the first generation EGFR inhibitors in this place. So I think as medicinal chemistry improves, the hope is that we'll develop better and better drugs in this space. If we go to the next slide, and indeed, we're seeing newer targeted therapies specifically for exon 20 mutations. So this is data that was also presented at the ASCO annual meeting. This is a relatively early asset. This is DZD9008. And here's another one of those waterfall plots. But in this study, we saw that about 40% of tumors were actually having significant responses to this agent. And so the hope is that as we look at, and this is looking at different dose regimens as well. So the hope is that this will continue to develop, and we'll see longer term follow-up data. Go to the next slide. And now I want to shift gears because right now we don't have an approved small molecule inhibitor for EGFR exon 20 mutation, but we do. As of earlier this year, we finally have an FDA-approved therapy for exon 20, and it's this drug, vantamab. This is an antibody. It's a bispecific antibody. And bispecific meaning, the way I think about it is think about a double-sided sticky tape. And essentially it's able to bind EGFR and it's able to bind MET. And we think that MET is one of those other receptors that can play a critical role in propagating the tumor growth. And if we go to the next slide, this is really some of the data that helped form the basis for the FDA approval. Another one of these waterfall plots. And we can see that this agent produced a response rate of about 40%. But as you can see from this plot, a majority of these tumors showing some degree of shrinkage. So most of these bars are below the 0 line, indicating tumor shrinkage. So that is very encouraging. And if we go to the next slide, this is taken straight from the FDA label. This is showing the safety profile of this agent. We tend to think about this as in specific grades. So the lower the grade, the more mild the side effect, or the higher the grade, the more severe. So grades 3 and 4 are considered severe. And fortunately, we're seeing that there aren't high percentages of grade 3 and 4 side effects. Most of these tend to be lower grade. Jack alluded to this, that one of the most common side effects we see with this agent is an infusion reaction. It tends to occur with the very first administration of the agent, and then once we get through that, it tends not to recur. Rash is one of the other more common side effects with this agent. So let's go to the next slide. And so putting this all together, for kind of both talks, we think about, there are sensitizing mutations to the classical EGFR inhibitors. These being the exon 19 deletion L858R, for those for first-line regimen is Poseotinib. We have more rare but sensitizing mutations. For those, we have Afatinib that's FDA approved. I mentioned I tend to use Osimertinib. And then for the exon 20 mutations, right now, my standard of care is still chemotherapy as an initial therapy. There are ongoing phase 3 studies comparing chemotherapy versus some of these newer targeted therapies. But we now have amivantamab that is FDA approved, but it's approved after chemotherapy. And so that's an important distinction from a lot of the other agents that we've heard today. So that, with that, I'm happy to take any questions and look forward to hearing your thoughts.